Hi guys, sorry I couldn't be there for the face-to-face ISCE revision session before, but I thought I'd put this video together to help you out in preparation for the exams. What I thought I'd do is talk a bit about the two different sorts of stations that can come up, talk about the sorts of things that could come up in them, how to structure for the different stations, and then maybe a bit about how to prepare for what could potentially come up in the second half of each station when the examiner is asking you data interpretation, clinical reasoning sorts of questions. So you're going to get two psychiatry stations. One is going to be explanation, one is going to be history and risk assessment. Of the two, explanation should be the easier station, and history and risk is probably going to be a bit more challenging because it's more to do in less time. So if we tackle the explanation station first, so they're all 50-minute stations. The explanation station, you've got 11 uninterrupted minutes with the examiner, with the actor, sorry, before the examiner comes in with their questions. History and risk assessments, it's 7 uninterrupted minutes with the actor before the examiner starts asking you more questions. So in terms of what can come up for explanation stations, treatments and disorders, and you might be asked to explain it to a simulated patient or relative, that kind of thing. So in terms of treatments, you've got first-line treatments essentially, and then the special ones that we use in secondary care. So things like SSRIs as a class, second-generation antipsychotics as a class with clozapine as a special, lithium as a mood stabilizer, ECT as a physical treatment, and CBT, cognitive behavioral therapy, as a psychological treatment as well. And these are all things that an F1 doctor would be expected to know to be able to explain to, a concerned relative, that kind of thing. So we break it down. So SSRIs as a class are all relatively similar in how they work, how you take them, and the common notable and serious side effects. So you can consider preparing for SSRIs as preparing for one thing essentially. It doesn't matter if it's explaining paroxetine or fluoxetine or sertraline or citalopram. They are all essentially the same. Excellent students might know the subtle differences between them. Things like, paroxetine having a very short half-life, so you're more likely to get discontinuation syndrome and that kind of thing. But in terms of revision, just being able to explain what they are as a class would be okay. Second generation antipsychotics then, these are broadly similar as a class. So risperidone, quetiapine, olanzapine are all broadly similar. Aripiprazole is a bit different, it's a bit weird, it's a bit like a Goldilocks kind of effect, in that it's almost the reverse of the others. And then clozapine is quite similar to risperidone, olanzapine, quetiapine, and then it's also quite different because of the serious side effects, agranulocytosis, and the fact that we only use it really for treatment-resistant schizophrenia. So preparing for those as a class, shouldn't be too much work either. Lithium, you just need to know about lithium. You just must be able to explain that to a patient and the risks. Likewise for ECT, you've been doing psychiatry for a while, so you should have had some experience with ECT, and you should be able to come up with a good explanation for that. And CBT, so make sure you're able to explain CBT. This is an incredibly widely used psychological intervention. It's used in primary care, it's used in secondary care, it's even, in self-help books and computer-based CBT packages and apps that people can download on their phone. So, at some point, a patient may want to discuss some CBT approach with a doctor, an F1 doctor or something like that. So you must be able to explain CBT. In terms of how to structure explaining a treatment then, if you preempted what a patient or concerned relative would want to know and be able to answer those questions, then that's essentially the trick. So most informed patients, if they've heard of something brand new, they'd want to know, well, what is it? What's it used for? How is it used? How quickly before it's going to help me? Is it going to help me? What are some side effects, if it's a physical treatment or something like that. And side effects we always try and break down into common, notable, and serious. And you would explain that as saying there are some common side effects that most people might get in the first few days or week or so. Notable side effects might make your life more difficult but won't be life-threatening. And serious side effects are rare but could potentially be life-threatening. And when you're explaining common, notable, and serious side effects, please break them up into those three categories for the benefit of the examiner, and it makes it sound really quite slick as well. And you want to be getting, ideally, around about 3 or 4, if you can, for each one for absolute top marks. For some conditions, obviously, there's more of a focus on the serious ones like clozapine. And for some treatments like CBT, we don't really talk about the risks of psychological treatments very much, but there can be risks associated with it. But when you're explaining CBT, you'd probably want to more focus on the tasks involved, the way that CBT is delivered and the characteristic parts of CBT. Okay, so you've said what it is, what's it for, why are you giving it to me, how do I take it, what are the side effects, the common, notable, and serious side effects. Patients may also want to then know, well, what are you going to do if this doesn't work? And you need a good response to that. So you might say, well, we treat everyone in a multidisciplinary team fashion, taking account of their needs, and we would look at maybe alternative biological treatments or psychological treatments or social interventions, and X, Y, and Z, that kind of thing. And you might need to also explain any particular information about that thing or that drug. So for lithium, you're going to be talking about toxicity and drug interactions and how to avoid toxicity and that kind of thing. For clozapine, you might be talking about drug interactions like with smoking. If you stop smoking suddenly, that can be dangerous for these reasons. So to explain those treatments, that should be fairly straightforward. That shouldn't take very, very long to be able to, to practice. In terms of explaining disorders, again, this shouldn't be too tricky. Preempt the questions that a concerned patient or relative might have and address them using lay terms, or if you're using jargon, make sure you explain it afterwards. So if you're explaining a disorder, let's imagine you're explaining a disorder, like schizophrenia or bipolar affective disorder or depression or post-traumatic stress disorder or Alzheimer's, or essentially anything that an F1 doctor would be expected to explain. A patient would want to know, well, what does that mean? What is it? Who does it affect? When does it affect them? What are the symptoms? What are the core symptoms? What's the prognosis? What are the causes? Causes can usually be broken down into, biological, environmental, that kind of thing. So what are the causes? Biological, environmental. What are the treatments? And you might talk a bit about, medication, psychological therapy, social interventions, because that's the same for pretty much everything. Excellent students might talk about risk to other family, to passing it on. If the risk in the general population is X%, what's the risk to my child or one of my brothers or sisters or something? And you may need to dispel any common misconceptions over a disorder as well. So common ones would be things like, around violence or around split personalities or around this or that kind of thing. In terms of what could come up, as I said, any disorder that you've come across could potentially come up. Some things are going to be far more likely to come up because we think they're far more important. So things like major mood disorders, psychotic illnesses, anxiety disorders, those sorts of things are in the upper part of the blueprint, I think, along with so psychosis, mood, BPAD, schizophrenia, anxiety-related conditions, addictions, those sorts of things. Those are the sorts of things that could come up. So you should be able to have a go at explaining those. Okay, and if we move on next to talking about the focused history and risk assessment station. So this is probably going to be a little bit harder because it is a short amount of time. You've only got 7 minutes with the actor before the examiner interrupts you. And what sort of thing could come up? It could be, take a history from this person with psychosis, and their risk might be of accidental self-injury, or their risk might be to do with vulnerability, or their risk might be to do with accidental harm to others, or suicidal thoughts, or something like that. Or it could be take a history from this person with post-traumatic stress disorder, and their risk could be around self-harm or suicidal thoughts or something like that. So how this station would go is you're outside and you're reading on the board, please go and take a focused history and risk assessment from this person presenting with problems with their mood. And you'd think, all right, okay, mood, so this is either going to be unipolar depression or bipolar affective disorder, depression or mania, or mixed with or without psychosis. So how do you go about doing this sort of station? We'd walk in and you'd say, hi, I'm Matt Hoskins, I'm a fourth year medical student. I understand you've come in today to talk a bit about how you're feeling. If it's okay, what I'd like to do is find out a bit more about what's been going on lately, ask you some questions about how you're feeling and what you've been up to, and then some questions about your background, and see if we can come up with an idea of what the matter could be, if that's okay with you. Could you just tell me, first of all, a bit about what's been going on to bring you in today? And then you let the actor go into their opening line, and they tell you a bit about what's been happening here, here, and here. And then you think, right, okay, this is either clearly depression or either clearly mania or something like that. And you need a good structure to be able to focus your history depending on which one you think it is, and it'll be quite apparent by how the actor is talking or acting, or that kind of thing. So if we imagine it is depression, because that's fairly straightforward, once you've got a bit of an understanding of what's been going on for the actor, over recent period of time, oh, I've lost my job recently, or I've been bereaved, or this has happened, you'd say, all right, okay, and could you tell me a little bit more about your mood? How have you been feeling? What about your energy levels? And can you take your mind off things? Can you still enjoy things lately? Has that been affected? And then you've asked about the 3 core symptoms of depression. And then I tend to break depression down into 3 core symptoms: biological, psychological, suicidal, psychosis. So how have you been sleeping? What's your appetite been like? Has how you've been feeling affected your concentration and your attention? Can you watch TV and those sorts of things? Psychological symptoms: how do you feel about yourself lately? Your self-esteem, your self-confidence. Sometimes when people get really depressed, they dwell on things that have happened in the past and maybe blame themselves a lot or feel quite guilty. Has that been the case for you? How do you feel about the future? Do you feel as though things, could possibly improve in the future? Do you think that you can be helped with how you're feeling? And then sometimes when people are feeling like you're feeling, they just don't want to wake up in the morning. Has that happened for you? Has it gone further than that? Have you felt as though you just didn't want to be alive anymore? Has it gone further than that? And have you thought about ways of wanting to hurt yourself or to end your life? And then screening for psychosis, depending on the kind of cause of it, you should always be asking, what's at the front of the person's mind, essentially, because psychosis is, not normally an afterthought in the back of your head. It's usually at the very front in terms of delusions, and it's at the front of your awareness in terms of hallucinations. So you might say, apart from what we've been speaking about so far, is there anything else that's been really on your mind lately? And if you're thinking depression, you might be thinking persecutory delusions or nihilistic delusions or those sorts of things. You might say, has anything been really worrying you or making you feel afraid or scared And once you get a bit of a flavour of what the thought is, and you think, this could be the delusion, you've got to do two things: establish the origin and the fixity. So you've got to be able to say, how do you come to know this was going on, and how convinced are you that this is the case? And then once you've got that, you can quickly then move on to looking if there's any hallucinations as well. So, okay, aside from that, have you had any other unusual experiences lately? Anything out of the ordinary happen to you over recent weeks or whatever the time scale is? Oh no, Doc, what do you mean? They might say, and you'd say, oh, well, what about anything like hearing voices if there's no one around? And when did that happen? Is that happening right now? And if that is happening right now, can you tell me a bit more about it? That kind of thing. And then you want to be moving on to the rest of the history, essentially. So you probably would have spent the first 3 or 4 minutes doing all that, introducing yourself, establishing what's been going on, the focused part of the, history of depression, core symptoms, associated biological, psychological symptoms, suicidal thoughts, homicidal thoughts, psychosis, and then you're going to be going on to the background. And at this point, these are going to be quite conversational, but quite closed questions for time's sake. And what you're essentially doing is telegraphing to the examiner that in a real world situation, you know how you would structure a history. And if you had adequate time, you would be covering all these things in detail. But for the purpose of an ISCE, what you're essentially doing is just showing that you'd ask about this, and this. And you'd say, okay, have you had any mental health problems in the past, especially things to do with your mood? Have you ever done anything to hurt yourself or anyone else in the past? Okay. What about any medical problems in yourself? Do you take any medications or drugs or alcohol? What about your family? Is there anyone in your family who has mental health problems? Who do you live with? What do you do? Any trouble with the police? And finally, insight. So what do you think could be the matter? Do you think you might be suffering from the symptoms of something? Do you think that could be symptoms of a mental illness? And do you think that's causing you trouble and we need to do something about it? That kind of thing. So that would be your structure for a focused history and risk assessment of depression. You would essentially then need to tailor that if it's a different disorder. So the latter part of that is always going to be the same. The specific questions in the first half are going to be different for different disorders. So if it's a different disorder, if it's something like mania with psychosis, you've got to be able to ask the right questions to characterize what mania is. So what are the characteristic ways it feels to be manic? Well, you've got persistently elevated or irritable mood, decreased need for sleep, increased energy, racing thoughts, and then the associated reckless behaviors. So things like, excessive spending, reckless driving, using drugs and alcohol, or having, using drugs and alcohol in ways that the person normally wouldn't, that might be dangerous, getting into arguments and fights, and becoming socially or sexually disinhibited, and those sorts of things. And then you go straight into screening for psychosis and suicidal and homicidal thoughts, as you would have done before for the depression one. And then the background, exactly the same as the depression one. If it was more of a history of first episode psychosis that's looking like schizophrenia, that kind of thing, you'd want to be focusing more on psychosis and more on first-rank symptoms of psychosis. So what are the first-rank symptoms? So things like echo de la pensée, hearing the voice, hearing your own internal thoughts out loud as a voice, running commentary, auditory hallucinations, voices heard arguing, delusions of thought interference, delusions of passivity as well. How do you ask those sorts of questions? Do you ever feel as though your thoughts are not private? What do you mean by that, Doc? Do you ever feel as though somehow someone or something can interfere with your thoughts in any way? As though they can broadcast your thoughts outside of your head for others to hear, or as though they can reach into your head and take thoughts out or insert thoughts that aren't yours into your head? Do you ever feel as though you're not fully in control of you, as though someone or something can actually somehow reach into you and control you, you feel, or the things that you want to do, or even movements of your body and that sort of thing? So for the different disorders, you just need to be more specific with the questions to encapsulate it. If it was something like post-traumatic stress disorder, you'd want to be asking, well, we know there needs to be a trauma, and there needs to be a month in between the trauma and the onset of the symptoms. So have you been in any traumatic events in the recent past? And if so, as a consequence of that, break it up into essentially 4 symptoms. Do you get nightmares and flashbacks? Do you feel on edge, easily startled, like you can't relax or sleep very well? Do you avoid thinking, talking, and doing anything that brings back reminders of it? Avoidance. And has it changed the way you think and feel about yourself and the world? Like cold and detached, or angry, or guilty, or shameful, that kind of thing. So if you can, encapsulate those 4 things, then you go into screening for suicidal, homicidal thoughts, psychosis, past psychiatric history, exactly the same as the depression one and the manic psychotic one and everything. In terms of the risk element of it, what you're trying to do is find out if there's a history of risk, if they've been having suicidal thoughts or homicidal thoughts or anything like that, and if they currently are having those thoughts as well. Everything that happened before the interview or the ISCE is history. What's going on during the ISCE or the interview is mental state. So if you're asking someone who, have you been having suicidal thoughts, and they say, yeah, I have been for the past few weeks. If you then say, what about right now? Then that's history and mental state, essentially, because you're obviously not expected to do a full mental state examination in an ISCE. That's unrealistic. That would be for a Royal College exam to do it in 7 or 8 minutes or something. But you will have to incorporate elements of a mental state when you're reporting, obviously your findings. You might say they've got a 3-week history of suicidal thoughts, but they currently deny having them today, that kind of thing. And when you're thinking of risk, there's a few different sorts of risk that might come up in an ISCE. Obviously, suicidal thoughts, homicidal thoughts, thoughts of wanting to hurt other people, accidental injury or unintentional risk to self and unintentional risk to others as well, and vulnerability. So I suppose some of these things might come up. You can imagine if someone is psychotic and driving, but driving at speed because they're trying to escape from people they think are following them. They're not trying to hurt anyone else. They're not trying to drive dangerously, but they are because of their psychosis, that kind of thing. Or someone who is, very anxious or intoxicated or something like that, that might be out walking in the streets very late at night without adequate clothes or footwear on, and they would be vulnerable to injury or from people taking advantage of them, that kind of thing. So you need to be able to think on your toes in terms of the different sorts of risk that could come up. Okay, is that recording? Yeah. No. Right, that's recording. Okay, so those are broadly the 2 different sorts of stations and the sorts of things that could come up. The trickier part for people in a lot of ISCEs is actually the second half or the second stage, where they've interviewed the actor and now the examiner is asking them some questions. So for an explanation station, there's not very much time left over once you've talked to the actor, so only 4 minutes remain. And a lot of times this will be some kind of data or clinical interpretation, where they might say, here's the patient's blood results, here's their ECG, here's their drug screen urine, that sort of thing. What's going on and how would you manage it? And then largely they'll take a back seat and not ask too many other questions, and you've got to be able to say, well, this is the full blood count of Mr. or Mrs. X, and I can see that there are abnormalities here, here, and here that shows that this could be going on, and how I would manage this is, and then you're essentially shifting gears and thinking more in a medical kind of way, because you might need to be thinking of, managing agranulocytosis in someone who's on clozapine, or you might need to think of managing lithium toxicity, or you might need to think of managing, something along those sorts of lines. So always have an ABCD approach. Always think where the patient needs to be to receive the correct medical care. Always think if they were in a hospital, I would want to be doing these investigations, and then I would want to be thinking of implementing these treatments. And always think, excellent students will always think, what would happen if the patient refused what you wanted to do? What if they had agranulocytosis and they had maybe signs of infection, but they were actually refusing to go into hospital? Or they were acting in a strange way, they were confused, they were delirious alongside it, that kind of thing. Excellent students would say, ABCD approach, I want to encourage them to get them into hospital. If they were refusing, I would want to assess their capacity using the Mental Capacity Act. From the information I've got, I'd consider they likely had a disorder of brain or mind, and they likely wouldn't be able to weigh up the pros and cons of a decision to be admitted into hospital. Once they're in hospital, they could be treated with proportional force and restraint against their will, in their best interests. And these are the things that I would want to do as part of that treatment, that kind of thing. Exceptional students would also consider that, if a person, maybe if they're on clozapine, they've had their red result, they've got an infection, they've got to go into hospital, you need to involve other specialists as well, don't you? So you'd want to be involving probably hematology, because they're the blood specialists, and probably a liaison psychiatry service within the hospital, because this person is now going to need an antipsychotic or some kind of treatment to replace the clozapine that needs to be stopped, that kind of thing. In terms of the other sort of station and the history and risk assessment, so you've got a lot longer with the examiner. They can ask you a lot more in terms of questions at the end. So the first thing they'll probably ask you is to summarize your findings, including level of risk and differential diagnosis, that kind of thing. So you should be able to and have had practice in presenting brief summaries to seniors, to consultants and things when you're on placement. So you should be able to briefly summarize whatever has come in the history and risk assessment part with the actor. And if there's anything that you have forgotten to ask about, mention it when you're summarising and saying, if I had more time, I would have liked to have also asked about previous suicidal attempts, or previous medication or drug and alcohol or whatever it is. Because examiners understand that it's a high pressure situation and time is very limited. But if you're still thinking of it, when you're summarising, of course mention it. And then there might be several questions that you'll get from the examiner at that point. It could be, here's the bloods, here's the urine, here's the ECG, here's whatever it is, what's it show and how would you manage it. But it might be more of a clinical reasoning question as well. They might say, 3 years have passed and the patient now presents in this way, which is different. What do you consider could be causing this, and how would you manage it? That kind of thing. So you might have to hear, with your psych helmet on, shift gears and think, okay, I've just taken a history from someone who had this, but I'm now being told 3 years later that this is going on. Don't assume that it's exactly the same thing connecting the two. You might need to be able to think, all right, okay, now I think the diagnosis is different and they might need this different treatment. Or it could be a psychiatric emergency. So how would you manage this psychiatric emergency? You've just walked onto a ward and you've been called by the nurses and they've said they found the patient in the bedroom in this way. How would you manage it? So when we think of psychiatric emergencies, the sort of things we tend to think of are violence and aggression, parasuicidal acts, so people who have injured themselves, they've cut themselves, or they have maybe tied a ligature around their neck, or they've jumped from a height or something like that. We tend to think of things like neuroleptic malignant syndrome, serotonin syndrome, and we tend to think of agranulocytosis, and we tend to think of lithium toxicity. So you should be able to think of those psychiatric emergencies and think through a systematic, methodical way of how to approach them all. And the good news is you already know this because you've been doing it for years. It's just a case of being able to do it and say it under pressure. So let's imagine someone has been found in a bedroom and they've cut their arm and there's a lot of blood everywhere. How would you approach that situation? How would you manage it? We'd say, well, first of all, I would immediately call for more help, and then if the situation is safe, I would approach, and I would have an ABCD approach. You'd want to be stopping, removing whatever is being used to cut, stopping the bleeding, addressing the wound and that sort of thing. The patient may need to go into hospital for further treatment. If they were to refuse to go into hospital, I'd want to assess their mental state under the Mental Capacity Act, and if they had a disorder of brain or mind, they couldn't weigh things up, proportional force and restraint, and that kind of thing. So those are the sorts of things you need to be thinking about. I'm sure you're all aware there's this book, How to Pass the MRC Psych ISCE, that I've given to the guys in the first block that were with me in Cardiff. They've taken photos and uploaded it to the Facebook group that you're all apparently a part of, the UFO Facebook group. So it was a good resource, good to refresh your memory about how to explain ECT, CBT, clozapine, lithium, SSRIs, that kind of thing. So very best of luck for this week. And if you've got any questions as well, you can always email me or Alan as well. Okay, thanks guys, take care.